Good evening, everybody, and welcome all of you to the live program number 128 at Orthopaedic Principles. We are back with our phenomenal faculty, Dr. Yogesh Joshi from Wrexham, United Kingdom. Dr. Joshi has a special interest in knee surgery, and today he's going to discuss about medial collateral ligament injuries. If you have noticed, Dr. Joshi has given multiple lectures before, and this is his fifth lecture with us, and this is going to be really enlightening. Over to you, Dr. Joshi.
Well, thank you so much, Dr. Gopalan. It's been a pleasure talking on your channel. And I've been following your channel quite a lot now. It's a fantastic resource for all the orthopedics trainees, and really congratulations for getting this type of channel started on YouTube. Today, I'm going to talk about medial collateral ligament injuries. It's a very common injury around the knee, and we'll just talk through the basics, anatomy, how this happens, and what to do when this happens, and give you a basic understanding as to why and how we treat this kind of injuries. So I'm Mr. Yogesh Joshi. I'm one of the orthopedic knee consultants at Wrexham Hospital. It's a beautiful part of the world. It's situated in the North Wales part of UK, and it's a wonderful place to be. If you guys wish to come and observe any of the surgeries, please let me know. So we'll talk about the anatomy of the MCL. As you know, it's the medial structure of the knee. It has got quite a few components. The main component is the superficial MCL, and the other components are the deep MCL, the posterior oblique ligament, and the posterior part of the capsule, the posteromedial capsular thickening, which is the whole part of the medial structures, deep medial structures, which we are going to talk about. So the superficial MCL is the most common stabilizer of the knee, and this is the one that gets injured, and this leads to instability on the medial side. The superficial MCL is attached just proximal and posterior to the medial epicondyle on the femur. And it runs straight down onto the tibia. Now onto the tibia, it has got two attachments. One is the tibial attachment, the proximal tibial attachment, which is attached around the groove where the semimembranosus is attached down here. And then it goes all the way down, and then the other part attaches to the posteromedial margin of the proximal tibia. The POL, or the posterior oblique ligament, is in very close proximity to the gastrocnemius tubercle. And it's just distal to that. So it's attached down here, and it goes obliquely and attaches to the fibers of the semimembranosus tendon. So these are the two structures that we are at the moment concerned about. The other structures are the deep MCL, which has got two components, the meniscotibial and the meniscofemoral, and we'll go through that as well. So looking at the superficial MCL again, so this is the femoral attachment of the superficial MCL. It is quite long. The whole length of the superficial MCL is about 8 centimeters. So it's quite a long ligament. If you see that when you dissect the knee during a total knee replacement, you will know that it's quite long. And then if you are going to release the MCL in total knee replacement, you have to go quite further down to correct the deformity. So it's quite long ligament. Now it's attached to the femoral side just at the proximity of the medial epicondyle. It's not attached to the prominence of the medial epicondyle, but it's a bit proximal and posterior. And this then goes all the way down south and attaches to the posteromedial border of the tibia. And it goes underneath the pes anserinus tendons. So if you lift the pes anserinus tendons, obviously there is a pes anserinus bursa there, and it's all attached down around the bursa. At the same time, you can have a look at the POL. So it has got an oblique, and the direction is a bit different from the superficial MCL. It is attached proximally at where the gastrocnemius tubercle is, just distal to that, and it goes obliquely. Now the POL has got three components. One is the superficial component, which is quite anterior, and it merges with the fibers of the superficial MCL. Now that is not quite a thick bundle. The thickest one is the central bundle. Now the central bundle goes right down and attaches to the fibers. This is the anterior fibers of the semimembranous tendons, and that is the strongest bit. If we do anatomical reconstruction of the MCL, then this is what we reconstruct. And then there is the capsular part of the POL, which is quite thin, and it goes obliquely and attaches to the semimembranous tendon, and some fibers of the capsular part of the POL attaches to the posteromedial capsule, which is also a strong structure. There is quite a lot of thickening of the posteromedial capsule at this part, and it also has got biomechanical function, and we'll go through that as well. Now looking at the deep MCL, as you can see, it attaches distal to the medial epicondyle and is deeper to the superficial MCL, and that's why it's called the deep MCL. And it has got the meniscofemoral component, and this is the medial meniscus down here, and the meniscotibial component. Now these are attached to around a small groove over the femur and a groove around the tibia. If these components are disrupted, and if you are going to reattach it during acute repair, you may have to put some anchors where these fibers are attached down here. And that's the reason we need to know the anatomy of the superficial and deep MCL. Going further, this is the posteromedial capsular complex, and this is the thickened part of the capsule. And as you can see, everything merges into a tissue, and you can see that's the band of the superficial MCL, that's the semimembranous tendon, that's the medial gastrocnemius tendon, which attaches to the gastrocnemius tubercle, and this is the adductor magnus tendon, which is attached to the adductor tubercle. So all these are landmarks are important. The three landmarks that we are interested in are the adductor tubercle, the gastrocnemius tubercle, and the medial epicondyle. So with that in mind, we are going to think about, if we want to reconstruct the MCL, how we are going to do that. And this is another picture, and this shows how the alignment of the different medial structures are. So the MPFL, the medial head of gastrocnemius tendon, adductor magnus tendon, the superficial MCL, and the POL, they are all attached around the medial side of the knee, and it's just a minor differences as where exactly they attach. And with the three bony prominences, we can then decide where to put our grafts to reconstruct these different structures on the medial side of the knee. So the superficial MCL is the strongest part of the MCL. So it resists the valgus load in all angles. Most important is that at 30 degrees and 90 degrees of flexion. It also controls the internal rotation in extension. And because at that point, it's very tight. It is not an isometric ligament. So it has got some anisometry, and some fibers are tight in extension and some fibers are tight in flexion. Similarly, the deep MCL is a secondary restraint for the valgus load. Now in a flexed and externally rotated knee, this deep MCL is going to be tight, and hence it controls the anterior drawer in a flexed and external rotated knee. Similarly, the POL and the posteromedial capsule are quite tight in internal rotation in extension, and hence in that position of the knee, it will resist posterior drawer of the knee. So all these components are important if you are going to look at the posteromedial side of the knee. Hence, the MCL injury is not only the medial side of the knee, causes the medial instability of the knee, but it causes the posteromedial instability of the knee. So even if there is a restriction or a laxity in valgus, always check the laxity in rotation as well, because it can lead to rotatory instability of the knee. How does it happen? It usually happens by a direct injury to the lateral aspect of the knee. Now, depending on the position of your ankle and the rotation of the tibia, different components of the medial side of the knee can be injured, and that leads to the different kinds of injuries that we treat. As you can see, there is a valgus stress of the knee when there is a direct injury. In an indirect injury, if there is no contact between, there's no contact when to the knee when the person falls, then obviously it's non-contact injury, which is uncommon, but you can see these kind of injuries, especially if they have a history of fall from height. And depending on the position of the ankle, different parts of the MCL can be injured. The most commonly injured part of the MCL is the anterior bundle of the superficial MCL. And obviously, history taking is quite important. And during the examination, you will see swelling, ecchymosis. If the capsule is ruptured, then you won't feel any hemarthrosis. You can get internal derangement of the knee as well. You can have common multi-ligament injuries as well. So if you have an ACL with MCL, you will have different kind of presentation compared to just isolated MCL injuries. The way we diagnose it clinically is by doing a valgus stress test. You do it in 0 degrees of flexion and at 30 degrees of flexion. At 0 degrees of flexion, you're checking for the POL, and at 30 degrees of flexion, you're checking for the superficial MCL. And that's how you can decide. If there is a gross instability, always check for other ligaments, especially the ACL, because the ACL-MCL combination is the most common combination. In chronic MCL injuries with the residual laxity, the patients can develop a valgus thirst gait, which is different from a varus thirst gait. So when the patient will walk, you will feel they're keeping the ankle internally rotated while the knee goes into a dynamic valgus. And this is classic for a chronic MCL injuries. Now, imaging on X-rays, it's quite uncommon to see anything with the MCL injuries. Sometimes you can see avulsion fractures of the medial epicondyle along with the MCL injuries, but it's very uncommon. If it's a chronic injury, you see calcification at the origin of the medial femoral condyle, and this is called the Pellegrini-Steddas lesion, which is basically a healed MCL injury. If you do an MRI scan, it can be graded into 3 types. One is a strain, where there is continuity of the fibers and no fiber is torn, but it's painful. In grade 2 injuries, there are disruption of some fibers, but not gross instability. There is a good endpoint. Whereas in grade 3 injuries, there is no endpoint. There is complete rupture of the MCL. Now, grade 3s can be divided into 3 types. One is a rupture of the MCL at the origin of the femoral side. One is a rupture of the MCL, superficial MCL, at the tibial side, and mid-substance tears of the MCL. The most common are the femoral-sided tears of the superficial MCL. They can be two types as well. So when the femoral attachment, if it's a well defined or and clearly identified on the MR scan, those will heal. But if there is a diffuse injury to the whole of MCL, which you can see in these MRI, where there is serpentine appearance of the MCL, they're very difficult to treat conservatively. Also, you look at the deep MCL and you can see they're closely approximating the medial meniscus, and you can see the tibial part is well attached, whereas the femoral component of the deep MCL is completely gone where it should have been attached. And this has led to the bleeding of from the knee to extravasate into the soft tissues. And this is because of the capsular, posteromedial capsular disruption. On the axial slides, you can see the superficial MCL is completely disrupted. And you can see the edema and the hemarthrosis that has been extravasated into the soft tissues as well. Now, this is an interesting one. So this MCL has been injured and has been disrupted on the distal side. So on the tibial side, the MCL has come off. And you can see the deep MCL is still attached on the tibial side. And when this happens, there is a risk that the MCL can flip and go over the top of the pes anserinus tendons. And if this happens, it's called a Stenner's lesion of the knee. And this is not going to heal. So these kind of lesions will need some kind of repair or reconstruction for better function of the patient. And you can see this is a total blowout. So you can see there is a diffuse injury to the whole MCL along with the deep part of the MCL. And you can't really identify the components here. And that is, even if this heals, it will heal in a stretched position and the patient will have a residual instability. Also to look on the axial sides are the posteromedial capsule and the POL. And you can see here on the axial side, these are injured. There's quite a lot of edema, hemarthrosis, and bleeding down here. And this basically indicates the POL and the posteromedial capsule have been injured. If you don't address this during the treatment protocol, it can lead to rotatory posteromedial instability. Most of the time in grade 1 and grade 2, as well as many of the grade 3s MCL injuries, you just treat it with bracing. It really works. You put them in a hinge brace, put them on a full range of movements, and get them to do quadriceps exercises, and it heals in about 6 to 8 weeks time. One thing you need to be aware of is the alignment of the leg. So if the leg is in a varus alignment or the neutral alignment, this will heal. So I tend to get them full weight bearing, full range of movements, just varus valgus stability, which is done by the braces. If the alignment of the leg is in valgus, that will lead the MCL to be healed in a stretch position. And in that case, I do advise patients to be non-weight bearing for 6 weeks so that it heals in a proper position and not a stretched position. So if a grade 3 MCL is clearly defined, you brace it for 6 weeks, and that's it. It should heal by itself. There are papers which show that the MCL can eventually heal up to 6 months. So there are patients who are not high demand patient who can be treated conservatively up to 6 weeks before deciding what next to do. If it's grade 1 and 2, you treat it non-operatively. If there is a grade 3 injury which is diffuse, then you may, in a high demand patient, you can offer acute repair plus or minus augmentation. Nakamura in 2003 demonstrated these diffuse injuries of MCL don't heal in an anatomical position. They heal in a stretched out position, and that can lead to residual instability. If it's a grade 3 injury with a tibial avulsion, and if it's a Stanners lesion, then obviously it's not going to heal, and it does require acute repair plus or minus reconstruction. In chronic laxity, if there is residual instability after you have treated it conservatively, then you can do a medial reconstruction. There are case reports with osteotomies for delayed laxity of medial collateral ligament, but it's for literature purposes. I haven't done any osteotomies for this reason. Also, to be aware of that MCL can be a part of multiligamentous injury, and in that case, I tend to operate on them if it's more than ACL, PCL, and MCL. You do repair it and augment it at the same time as reconstructing. If it's just an ACL and an MCL injury, then you have got two options. You can either go directly repair the MCL along with your ACL reconstruction, or you treat the MCL conservatively. And once that has healed and the patient is symptomatic for ACL instability, then you reconstruct the ACL. If you are doing an acute repair, then you identify the bundles and then repair it anatomically using anchors to fix it directly to the bone. At the same time of repair, I tend to augment the repair with help of, I use internal brace, but any kind of tape with anchors to make it sustainable, you can use it. And this can be done minimally invasive as well. If you feel to reconstruct the MCL, then there are various options. The most commonly done is the Laprade technique, where you do a double bundle, which are separate bundles, and you do an anatomical reconstruction for the superficial MCL as well as the POL. You also need to reef the posteromedial capsule because that will be lax as well. Same as the posterolateral corner repair. The other technique is what we call a skis technique, and this can be done with a single graft, single tendon graft, and you just loop it at the medial epicondyle and use the two limbs to reconstruct the POL and the superficial MCL. And then there is the weave technique, where you can still use one tendon and reconstruct the POL and the superficial MCL at the same time. So this is the anatomical reconstruction. So it requires two tendons, where you reconstruct the POL separately and the superficial MCL separately. The modified version is you can use one tendon and use one femoral attachment to reconstruct the POL as well as the superficial MCL. If you are planning to do a minimally invasive kind of repair or reconstruction, this is the landmark that you need to look radiologically. So in a true lateral view of the knee, you draw a line from the posterior cortex of the femur, and the point where it intersects the Blumensack line, that's where the insertion of the MCL is, superficial MCL is, and that's how you reconstruct it. Thank you so much. If you have any questions, I'm more than happy to answer them.
Thank you, Yogesh, for yet another fantastic lecture. Your lectures have been so engaging. A few questions. One is, what is the incidence of an associate ACL injury if you have a grade 3 MCL injury?
I think it's about 5 to 10%. So it's, MCL injuries are quite common. So, MCL strains, MCL type 2 injuries are quite common. So if you have a minor injury knee clinic that is going on, you will see at least 1 or 2 every day. Whereas if you
have a type 3 MCL injury.
Yeah, so if it's a type 3 MCL injury, the diffuse type 3 injuries, it's more common to have an ACL injury in that. The incidence is about 5 to 10%, not much.
You say that the incidence of
Ligamentous injury,
ACL in a grade 3 MCL would be around 5 to 10%.
5 to 10%.
The other question is, you showed the anatomical location on the CM or the radiograph if you take a lateral X-ray. Now, how far is it from the Shortall's point, that is the MPFL?
Yeah, so if you go back to the diagram, it is anterior and distal to the Shortall's point. So it's if you draw the same lines, the Shortall's point will be more proximal and posterior to what the MCL attachment is, superficial MCL attachment is.
Would you mind taking that slide if it's possible, or if it's
Yeah.
difficult, you can let it. It's okay.
Let's see.
We have to start from beginning, is it?
No, it should be able to get.
Okay. No, the reason I'm asking is you drew a line that is along the posterior axis of posterior condyle of the femur.
Yeah.
So yeah, so you drew a line along the posterior condyle of the femur, and then you drew a line along the Blumenstadt. That's it, right?
Yeah, so where the posterior part, if you draw a line through the posterior border of the femur, where it intersects the Blumenstadt line, that's where the attachment of the superficial MCL is.
That's it. Okay, because
the MPFL attachment is more proximal to that.
Okay, so in an easier way, can we say that the MPFL is at the top of the posterior condyle, posterior most part? Is in line with that?
Yes. If you look at the anatomical structures, let's see. So there you go. So that's the MPFL. It goes from the patella, the proximal part of the patella, all the way to the medial epicondyle down here. And it's anterior to the adductor tubercle and posterior to the medial epicondyle, which is here. That's the medial epicondyle. So it's quite far away from the medial epicondyle and in the proximity of the medial gastrocnemius tubercle and the adductor tubercle. Whereas the superficial MCL, if you palpate the medial epicondyle, where it dips down, that's where the superficial MCL attaches. So if you're doing an open repair, it's very easy to find where it attaches, because you just find the medial epicondyle, go just posterior to that, and where it dips down, that's where the superficial MCL is attached.
And always it is better to do a radiological. For example, when you do the MPFL reconstruction, you take the lateral X-ray, you draw the Shortall's point and then do it, right? So similarly, do you think that much of precision is required for the MCL as well?
I do it because medical legally, then if it does fail in future, then medical legally you can say you were in the right position as well. So it's quite. I think in my practice, I do it routinely to put the guide pin exactly where I think it is, and then have a X-ray as well, so that I know for sure that I'm in the right spot. Sometimes if you're doing a minimally invasive reconstruction, then it's very difficult to make out whether this is the medial epicondyle or the gastroc tubercle or the adductor tubercle. And it's then better to use a guide wire and get an X-ray as well, so that we know exactly where we are.
And all this is important when you come in terms of an MCL reconstruction, isn't it? In an acute MCL injury, these landmarks are less important, is it?
No, same landmarks. So if you're doing an acute, you will be using a bigger incision because, especially in the medial injuries, you will have the POL and the MCL, superficial MCL as well, which is disrupted. And then you find both the bundles and you just reattach where they have come from. So I think the landmarks are important, even in acute repair. At the same time of repair, I do augmentation as well. So I use a tape to augment the repair, which just gives a better kind of stability to the whole construct so that it heals properly.
What kind of tape do you use?
I use the internal brace with Arthrex, but there are various tapes that are available.
Now, the reason I am asking is I've done a few MCL repairs. So whenever I go in, I find that if it is a tibial avulsion, there's a thick tissue there. So it's easier for me to identify the avulsed MCL and get it back into position. But when I go into the femoral side, it's quite difficult because just a diffuse tissue around. So
It is.
it's very difficult to find the exact superficial MCL and the POL. What is the experience?
Yes. So that's what happened. And the anatomical slide, where is it gone? I'll show you one of my slides. They're all mingled up and it's the same. So you can't really identify in an acute situation. So if you see, the whole medial side is a complete complex. So you can't really make out, but the superficial MCL is still quite thick, and the POL central band, you will find these two are, the whole tissue gets that both bundles, and just pull it back together, see where the point is, and just put anchors there and just tie the whole tissue on the top. So the anchor should be at the point where I described, and that just gives an anatomical position to the whole complex.
And when you're doing a reconstruction, you are basically, you get on the femoral side, you're fine. But on the tibial side, you're looking at the attachment of the superficial MCL, isn't it?
That's correct. So on the tibial side, so there are two attachments of the superficial MCL. So if you go back to the diagram, so there is one which is proximal, and then the one which is distal, the superficial MCL. So I put a small anchor down proximally here, about 1 centimeter distal to the joint line, to tie my tendon down there. And then the definitive anchor will be just anterior to the posteromedial edge of the tibial crest, and just anterior to that, about 6 centimeters distal to the joint line. So those are my landmarks for the tibial side. Once I do the superficial MCL, I then use my second arm to go posteriorly where the attachment of the semimembranosus tendon is, and that would be the other limb that will reconstruct my POL. And once I do that, I then reef the posteromedial capsule to the tendon and do like a capsular shift, so that the posteromedial capsule is also incorporated in the whole reconstruction.
I think, yeah, that was really nice of you to explain so much in detail. Dr. Joshi, I think that's all the questions that we have. Thank you for yet another fantastic session, going into so much into detail about the anatomy. It's such a great learning experience with you. Thank you once again for joining us. And really, we are all waiting for the next lecture.
Thank you so much, Dr. Gopalan. It's a pleasure.
Thank you. I'll end the session.